Okay, so I have to use my phone mic, so that's why my phone is like sticking out, okay? But we just finished wrapping up cell like general overview of cancer. So now we're transitioning into our cancer exemplars. So our cancer exemplars for hopefully go like this. So our cancer exemplars, I hope y'all can hear me and not that plane or whatever that is. Our cancer exemplars, we have Cellrate 1, which is breast cancer, bladder cancer, and colorectal cancer, which we know is the colon and the rectum. Okay, so we're just going to go through the disease maps for each one. We already have a good understanding of what cancer is. So now going through the specific types of cancer, it should click as long as we understand what the function of the organ that's affected is, right? And we know cancer is uncontrolled cell growth, um, and it pretty much just makes the organ function go haywire. Pretty much, it's no specific ups, it's no specific downs. It can go either way. Unlike something like hypothyroidism, we know if things are going down. Okay, so starting off with breast cancer, I have my iPad. So starting off with breast cancer, the patho, we know cancer in general is just uncontrolled cell growth. So this is just uncontrolled cell growth in the breast, right? So inside our breasts, women, we have we have lobules, and we have ducts. I think that the ducts are what bring the fluid through the lobules. I could be wrong. Just know you got ducts and lobules. You can have cancer in either or, okay? And cancer spreads through lymph or blood. We know that already. So, what are the risk factors for breast cancer? So, you have age, you have genetics, being female, right? It's a one in eight females will develop breast cancer. 1 in 1,000 men will develop breast cancer. Having dense breasts, family history, past history of breast cancer, because we know cancer is stubborn, it doesn't like to go away. So even if you got treatment and it went away, it's a chance that it may come back. Chest radiation, oral contraceptives, no kids or having kids after 30, not breastfeeding. I'm gonna have to look into like the patho and like the reasoning behind that, but just from me guessing, I'm guessing that not breastfeeding could cause breast cancer due to those ducts and lobules, maybe. Hmm. Obesity, a high fat diet, and alcohol. So, what would make us suspect breast cancer? Like, what? How do we? What will raise a concern? We have new lump found in the breast shape changes, swelling, changes to the way your nipple looks, so it can be inverted or it just like goes in, it's not like sticking out. Having discharge from your nipple, such as blood or pus or something like that. Remember, cancer cells just go haywire. It is no definite up or down. Any type of weird, sudden changes, and it's happened swiftly, we suspect cancer. And remember that word swiftly, because with cancer, the cells are rapidly growing at an uncontrollable rate. Okay, so now we know our signs and symptoms. How do we diagnose it? We have a couple different tests. I mentioned them already in regular cell rate, right? So I'll mention them again since we're specifically talking about cancer, because I kind of just named them all. But for breast cancer, it's a mammogram. Look, they take your titties, they smash them down on the table, and yeah, they look for the lumps and they analyze and all the things. Ultrasound, I mentioned that in the first video. We can, if there's a lump found, lady comes in, complains of a lump found in her breast, doc may order an ultrasound. And with this ultrasound, we're going to look at the breast, and we're going to see where that lump is, and we're going to look and see, is this lump fluid filled? If it is, maybe it's a cyst or something like that, right? But if it's not, and it's just like solid, that, my friend, is giving cancer, okay? Hang on, I'm trying to get myself situated because I'm about to be leaving from around here because I don't like that, the movement around here. People walking, I don't know. And this used to be my little spot. We can do an MRI, but we know that the definite way to diagnose cancer is a biopsy. That is the gold standard. Okay. Possible complications of breast cancer. What is the worst case scenario? How could this go wrong? What am I gonna keep my eye open for? Pain, shoulder immobility, lymphedema. What kind of treatment or medication can I see in a patient with breast cancer? Surgery, right? Where they go in and cut your boob, they take it away. Chemo medication, radiation, targeted therapy such as brachytherapy, where they go in and do internal radiation, very close to the tumor, precise internal radiation, immunotherapy, try to stop that rapid cell growth, and then hormonal therapy. So I did not mention this in the first video, but certain types of cancer need certain types of hormones to grow, okay? Such as estrogen or testosterone. So that's what that hormone therapy is. Will block certain hormones that the cancer cells are using to grow. So what are our interventions for a breast cancer patient? We know we have independent, we have dependent, we have collab, and we have patient teaching. Our independent interventions are going to be assessing vital signs. It's going to be assessing pain. If my patient had treatment, if they had their boob removed, I'm looking at the incision. I'm looking to make sure that it's healing properly. And if they're receiving radiation, I'm looking at skin. I also want to monitor weight. I want to monitor mood because we know that our medications have a lot of side effects, right? A lot of serious side effects. And I mentioned also in the last video that as nurses, we provide total patient care. So we're concerned about emotional things just as much as physiological, okay? We're monitoring mood and nonverbal cues. We're going to encourage coughing and deep breathing. We want to promote mobility. This is more so for that patient that had that surgery. You know, these are like post-op interventions. Supporting body image. All of those things fit under that post-op breast surgery patient. I got 20% of my phone. Dependent. These are our doctor's orders, things that we cannot do alone, right? So we're going to admin chemo and radiation meds. We know we need a second nurse's opinion. We know we need proper PPE. We know that all RNs cannot just hang chemo meds. You have to have certifications to do this, right? Requires additional training. We can admin the hormonal therapy if that's prescribed. Any orders that the doctor puts in, we're carrying it out, okay? Pain meds, hormonal therapy, radiation, chemo meds, wound care. If they have a JP drain, making sure that that's like half squeezed, right? Suctioning. Then we have collab. Who are we collabing with? Oncology. Why? This is cancer, right? That's obvious. Dietary. We said that a lot of times they may not have an appetite. Mucositis is a common side effect of a lot of cancer medications. So we want to make sure we're avoiding that. We want to make sure they're getting adequate nutrition. That's why we do dietary. PT for shoulder mobility, especially our patients that have that pain or that had a mastectomy. and had their breast removed. Um, Coordinate with wound care nurse, social work. Okay, what am I teaching my breast cancer patient? I'm teaching my patient the plan overview, right? And what you'll see modern day is a lot of textbooks, a lot of PowerPoints, a lot of nursing literature no longer calls the patient, they call it the client. And we use the word client to try to evoke the sense of it's a partnership rather than patient, right? But old habits die hard. I still say patient, lots of people still say patient. But in the books, you'll see client. And part of that reason is because it's a partnership. So, with that being said, you want to make sure that your client is aware of their treatment plan. They know that, hey, I'm going to do my best as your nurse to take care of you. Your doctor's going to do their best to take care of you. But you still have a role here, aside from you just being sick. You still have to actively work to get better, right? We're all in collaboration with one another, right? So making sure they understand the treatment plan, they understand exactly what we're doing, why we're doing it, and how we're doing it, right? That's why patient education is such a big part of nursing because if your patients don't understand, do you think they're going to do? No, I'm not going to do anything that I don't understand because I don't understand the importance of it. So you need to make sure that they do, okay? Make sure they understand the side effects of chemo, radiation, and hormone therapy. They know those infection risks, those bleeding risks. They know no fresh flowers. They know to avoid sick people. They know to avoid crowds. They know to try to avoid injuries. They know to use caution and alternatives to hair removal, right? Avoiding those razors, no aspirin, no NSAIDs, all kind of things like that. If they have a wound, they know how to provide proper care for that wound because the last thing we want is for that wound to either become infected or to bleed because we know they don't have good defenses against those two, okay? Lymphedema precautions, that's so common with breast cancer. And just keep your eye on it, right? So we're looking for that lymph to be swollen, that lymph node to be swollen, okay? Teaching them the importance of nutrition. So again, infection risk, right? They don't have much defense. So it's important that they understand that they need to eat high protein meals as long as it's not contraindicated with any other medication that they're taking. We want them to eat high protein meals so that way we can kind of give them a better try to even the playing field for them, okay? Um oh, they almost fought. Not fought right. Um and then also I mentioned earlier when I said about collabing with dietary that they may not have an appetite, right? And that's okay. If they don't have appetite, do you know what that means? That means we need to do smaller, more frequent meals and we need to make them count. So how do we make our small frequent meals count? We go high protein, we go high calorie. We make sure that they're getting adequate nutrition. So nutrition is important and they need to know that, okay? We need to teach them, when do I report infection? They report infection immediately, okay? So what it should say is, how do I spot infection early on, okay? Fever, chills, uh, feeling hot, just feeling, all of a sudden weak or down, or feel like coughing up mucus, coughing up blood, changes in your urine, anything like that. Coming in contact with a sick person and then all of a sudden you get a cough, call your doctor if you got cancer. Support group options. So remember, I keep talking about total patient care. We're concerned about emotions just as much as physiological issues. So we need to make sure that our patient has, um, like a great quality of life, as great as we can possibly help them have. So we want to make sure that they have resources, they have a support group, right? If they have family, that's cool. But if not, we definitely want to make sure that we're giving them pamphlets to cancer survivor support groups or, people with active cancer, whatever. Okay. And that is breast cancer. I am going to do bladder cancer and colorectal cancer at home. Okay. Because I can't get around it. But that is the gist of it. I'll probably do another video, like maybe going more in depth on it, but that's the gist of it.